And here I draw your attention to those cytokines, and specifically interleukin-6. Others have investigated the effect of exercise and diet on inflammation, such as the authors of this paper. And again, you'll see that interleukin-6 appears across their findings. These authors summarise the links between diet and inflammation as far back as 2006. And again, you'll note that inflammatory cytokines, especially IL-6, sit at the centre of their model. And one last example from 2011, showing the influence of inflammatory factors on neuroinflammation and microglial activation as a factor in multiple diseases, some of which are now being shown to be responsive to PBM. And again, please note that interleukin-6 sits at the centre of this framework. We brought these ideas together in a paper published last year, which you can see the citation at the bottom right. In this framework, we propose that by combining PBM directed at the abdomen and the large muscles of the legs, we expect that we can down-regulate the local inflammatory response, either through activation of the microbiome gut-brain axis and or the hypothalamic pituitary adrenal axis, or even through a direct effect on mucosal neurons, which I'll come back to in a minute. Doing so should enhance muscle performance, thereby contributing to increased physical activity, which may further reduce the inflammatory effects of IBD and reduce the peripheral neuromuscular fatigue. If inflammation and peripheral fatigue is reduced, we believe that depression and central fatigue will also be reduced via the neuroimmune system. We know from the literature that a number of inflammatory cytokines, such as those listed on this slide, are central to symptomology in diseases characterised by inflammation. We also know that these same cytokines have been found to be modulated by PBM, which in our model may help to reduce pain. And you'll note the appearance of interleukin-6 in these lists, which I've been highlighting because it has dual anti- and pro-inflammatory roles for controlling local or systemic acute inflammatory responses, thus making it a great target for PBM research. If PBM is effective, as we expect, and as each of these factors gradually improves in our participants or in future patients, we expect people with IBD will be more likely to feel greater appetite and potentially improve their dietary intake, which has its own benefits. Finally, if we were to include transcranial PBM to the protocol, we could also expect to positively influence the depression that's associated with IBD. In addition to the integrated effects we proposed, last year it was shown that the colon has 5 types of mechanoreceptors that sense gut distension and pain, similar to the skin. In the skin, these peripheral nerve fibres sit very close to the surface and therefore are very amenable to light quanta. Because we know that skin pain receptors respond to PBM, as shown by numerous authors, including my Australian colleague Dr. Roberta Chow, it would seem reasonable that gut receptors will also respond to PBN if we can get sufficient light contact to the target tissue. And that's the reason why we're currently using laser PBN delivered by a multi-diode cluster array. We've published the protocol for our study, as you can see in the citation on this slide. In brief, we're using a 904 nanometer laser cluster array applied to the abdomen and to the large anterior thigh muscles. We target the abdomen to target the inflamed gut, and we target the thigh muscles with the aim to reduce peripheral fatigue. Participants act as their own controls. We do all baseline assessments at the commencement and end of a 10-week no treatment period before the participants undergo once weekly PBN for 10 weeks, then further assessment at the end of the treatment period. And then all participants are observed again for a further 10 weeks of no treatment before their final assessment and exit from the study. Our primary outcome measure is fatigue, for which the study is powered. We have completed recruitment of our target of 24 male and female young adults between the ages of 18 and 35 years who have medically diagnosed IBD and whose primary symptom is fatigue. For inclusion in the study, the participants were required to be in a non-flare state. At each of the highlighted time points, we're collecting physical measures from blood and stool, including fecal samples for microbiome analysis, and patient-reported measures, including fatigue, depression, and physical activity. Pain measures are assessed weekly throughout the 30 weeks of the study. We're still finalising the treatment and follow-up stages for the last few participants, but today I'll summarise for you a little bit about just a few of our interim results.